Hello everyone, this is Dr. Priyanka Agarwal here. We are preparing pharmacokinetics for our exam in this video. Okay, so as you know, we are already done with absorption and distribution in part 1 and part 2 video. We will be doing metabolism or biotransformation in this video, focusing on these 4 questions. Okay, so let's start. So as you can observe, biotransformation itself is a question. So we will first cover that. We will cover biotransformation in very easy way in the 4 headings. Okay, so first heading will be what does it mean, next where does it happen, next what are the reactions involved in it, and what enzymes help in it. Okay, so let's make it very easy. Okay, so what does biotransformation or metabolism means? So as you can understand from the term biotransformation, okay, so bio is in the body, transformation is chemical change. Okay, so inside the body there is chemical change of the drug. Now the question is why and what is the need of this chemical change? So this leads to inactivation of drug. So this is the main purpose of metabolism inside the body. So as you can notice from these diagrams here, imagine this is your active drug. Okay, so this is converted to inactive drug. Okay, there are 2 other things, we will go with each one. Okay, now first we will see the inactivation. So during inactivation, lipid soluble drugs are converted to lipid insoluble drugs. So this is what is happening during inactivation. Now the question is why the lipid soluble drugs are converted to lipid insoluble drug. Okay, so to understand this, let's go to our nephron. Okay, so let's understand something really basic here. With inactivation, we want our drug to be excreted out, right? So the purpose of metabolism or biotransformation is we want to make the drug so that it goes out of the body. Okay, so for that, drug should remain in the renal tubule, right? That means it should not be absorbed into the blood, right? It should not be absorbed into the blood. So all these membranes are made up of what? Lipid. Okay, so if the drug is lipid soluble, it will be able to cross this membrane. Okay, but what do we want? We want the drug to be inside the renal tubule to be excreted. So we convert the lipid soluble drugs to lipid insoluble drugs. Okay, so I hope you understand it now, that purpose of biotransformation or metabolism is converting lipid soluble drug into lipid insoluble drug. Okay, so that they remain in the renal tubules and are not excreted. Okay, example of such lipid soluble drugs would be lidocaine and paracetamol. Okay, now if the drug is already lipid insoluble, for example gentamicin and neostigmine, there is no need of metabolism, right? So they are already there in the renal tubules, so there is no need of any metabolism. So they are mostly not metabolized and are excreted unchanged. So they are excreted just like that, they are not biometabolized. Okay, now so you understood about the inactivation of the drugs. Now move on, let's move on to the next points. So sometimes what happens, before getting inactivated, drugs get converted to active metabolite from an active drug. Okay, so they also form active metabolite from active drug. For example, active drugs like diazepam and morphine, okay, they are converted to desmethyldiazepam and morphine 6 glucuronide. Okay, so the active drug is converted to active metabolite and then it is inactivated. Okay, in some cases what happens, when we take the drug in inactive form or prodrug, okay, so it is converted to active metabolite first, then it is inactivated. So we also form active metabolite from inactive drug or prodrug. Okay, so what are the examples? So for inactive drug, example would be levodopa and enalapril. They are converted to dopamine and enalaprilat. Okay, so prodrug is also a question that we will study as we go ahead. So you understood about the 3 points, like there is inactivation of drug and sometimes there are also formation of active metabolites from active drug and from inactive drug. Okay, so same thing is summarized in this diagram. So main purpose of biotransformation or metabolism is inactivation of the drug. Okay, now sometimes the drug is directly converted or before or in some cases it is converted to active metabolites from active and inactive drug. Okay, so this is about the first heading, what does biotransformation means. Now, what is the site? Where does biotransformation happen? So it is happening mainly in the liver. Okay, so it is happening mainly in the liver, and it is also happening at kidney, intestine, lungs and plasma. Okay, so these are the other locations. Now, what are the reactions involved in biotransformation or metabolism of the drug? So reactions are basically classified into phase 1 reaction and phase 2 reaction, which are also called as, phase 1 is also called as non-synthetic and phase 2 is also called as synthetic. So let's understand and make it very easy. Okay, so as you can understand from the term non-synthetic, synthetic. So non-synthetic gives the feeling like they are not being so useful. Okay, they are not giving us something useful. This is giving something useful. Synthetic is giving something useful. So actually that is the meaning. So function in this non-synthetic reaction, what is happening? Functional groups like OH, COOH, CHO, NH2 are generated or exposed. And in this reaction, the whatever metabolites are formed, they can be active or inactive. So if they are active, is our purpose is getting fulfilled? Are we getting an inactivated drug? No, right? They have to again undergo phase 2 reaction to get to convert it into inactivated drug. Okay, so maybe that is the reason they are called as non-synthetic reactions, because they are not giving us the fruitful results. Okay, so reactions here are oxidation, reduction and hydrolysis. Done. Understood about the non-synthetic or phase 1 reaction? It's easy. Non-synthetic means here the functional groups are exposed and sometimes metabolite can also be active here. In phase 2 or synthetic reaction, what is happening here? Here endogenous water soluble substances, means we are making the drug lipid insoluble. Lipid insoluble is nothing but water soluble. So water soluble substances are combined with drugs or the metabolites of phase 1 reaction. Okay, and here whatever metabolites are formed, they are mostly inactive. Okay, so we got our purpose fulfilled. Okay, so we got the drug inactivated. So metabolite formed here is mostly inactive and it is readily excreted. Okay, so what are the reactions here? So reactions are acetylation, methylation, glucuronide, sulfate, glycine and glutathione conjugation. Conjugation means adding something. Okay, so all these things, glucuronide, sulfate, glycine, glutathione will be added to the drugs, making it inactive. Okay, so again the same thing is summarized in this diagram. So we have a drug. If it is lipid insoluble already, it will be excreted unchanged. If it is not, then it can undergo phase 1 reaction. If the metabolite is inactive, it will be excreted. If it is not, it will undergo phase 2 reaction and then it will be excreted. Okay, I hope you understood. The biotransformation reactions. Okay, if you are not understanding anything, just let me know in the comments. Now let us move on to the enzymes in biotransformation. So what enzymes help in these reactions? Okay, as you know, inside our body all the reactions are catalyzed by enzymes. So in biotransformation also we have some enzymes. Okay, so we have, like, they are classified into two. We have microsomal enzymes and we have non-microsomal enzymes. So let's understand basics of these. So what do you understand by microsomal? So these enzymes are located in the microsomes. Okay, microsomes of smooth endoplasmic reticulum of liver and other tissues. Okay, so what do you mean by microsomes? So microsomes, as you can see here, they are small sealed vesicles that are created when the cell endoplasmic reticulum is fragmented. So these microsomes are nothing but they are parts. So this is the diagram for the liver cell. Okay, not the liver cell, sorry, this is the diagram of the normal animal cell. Okay, so these are endoplasmic reticulum. Okay, so if they are fragmented, we get our microsomes. So they are the part of smooth endoplasmic reticulum. That's what we understand here. Okay, so if they are located in this smooth endoplasmic reticulum parts, they are microsomal enzymes. Okay, so and they are located in liver and other tissues. So what are the examples? Cytochrome P450 and monooxygenase. Okay. Now what do these enzymes do? So they catalyze most of the oxidation, reduction, hydrolysis and glucuronide conjugation. Okay. So if you notice, microsomal enzymes, they are helping in non-synthetic or phase 1 reaction. Okay, they are helping in oxidation, reduction, and in phase 2 they are helping only in which conjugation? Glucuronide conjugation. Okay, so they are helping in only glucuronide conjugation. Okay, next, they are inducible. It's written here they are inducible. What do you mean by they are inducible? That is our next question. So as we go ahead, you will understand this. Now, what do you mean by non-microsomal enzymes? So obviously they are not in the microsomes. So they are located in the cytoplasm and mitochondria. So they are located in the cytoplasm, or this brown color thing, that is the mitochondria, okay, of the liver, other tissues, and they are also there in plasma. So that is the difference. Here microsomal are not there in plasma. Non-microsomal enzymes, they are also there in plasma. Now what are the example? Most conjugates, esterases are the examples for non-microsomal enzymes. Now what do? They catalyze all conjugates except glucuronide conjugation and some oxidations and reductions, and they are not inducible. Okay, so if you notice here, non-microsomal enzymes, they are mainly helping in synthetic reactions. So all conjugates are non-microsomal, and some of the oxidation reductions are also happening with the non-microsomal enzymes. Okay, so I hope you understood about the enzymes in biotransformation. So before moving on to the next question, let's quickly summarize biotransformation. Okay, so we understood the main purpose of biotransformation is inactivation of the drug. Okay, so drug is getting inactivated. Okay, now where it is happening? It is happening in the liver mainly. What are the reactions? So we have non-synthetic, we have synthetic. In non-synthetic, the drug can still be active, which need to undergo phase 2 reaction. In this, it is inactive. Okay, so these are the reactions happening in phase 1. These are the reactions happening in phase 2. What are the enzymes? If they are in the microsomes of the smooth endoplasmic reticulum, they are microsomal enzymes. If they are in the cytoplasm and the mitochondria, they are non-microsomal. Okay, and microsomal enzymes may mainly helping in the phase 1 reaction, and non-microsomals are helping mainly in the synthetic reactions. Okay, understood? Okay, so let's move on to the next question, that is microsomal enzyme induction. So when you understand this question, you will understand what do you mean by here written is inducible. So what do you mean by this? You will be understanding. Okay, so what is microsomal enzyme induction? So till now we understood what do you mean by microsomal enzymes. Okay, so now let's understand what do you mean by microsomal enzyme induction. Okay, so sometimes what happens, some drugs, chronic alcohol, or the insecticides. So many drugs like phenobarbital, phenytoin and carbamazepine. So these are anti-epileptic drugs. Okay, rifampin and isoniazid are what? Anti-tubercular drugs. Okay, and this chronic alcohol, insecticides and some carcinogens, these are called as enzyme inducers. Okay, now what these things will do, they will interact with the nucleus in the cell. Okay, in the cell they will interact with the DNA in the nucleus, and they will increase the synthesis of some proteins. Okay, so now what are these proteins? These proteins are nothing but microsomal enzyme proteins. Okay, so these are microsomal enzyme proteins. Okay, especially these are cytochrome P450 and glucuronide transferase. Okay, so now what we are getting? We are getting our microsomal enzymes, right? So because we are we are getting more of these enzymes, this will increase the metabolism of drugs by 2 to 4 folds. Okay, so what did we understand? Microsomal enzyme induction means some drugs or these things, they are increasing the metabolism. Okay, and they are mainly acting on microsomal enzymes. So that is the meaning of being inducible here. Understood? Right. So this is the meaning of microsomal enzyme induction. Now let's understand what is the clinical relevance of it. So when there is increased metabolism, and when it is metabolizing its own, like if the drug is metabolizing its own, if the drug is increasing its own metabolism, then there will be tolerance, means how much you give the drug there will be no effect, because the drug is metabolizing fast, right? So the tolerance will develop if the drug induce its own metabolism. Okay, for example, in the case of carbamazepine. Okay, now if the one drug is metabolizing another drug faster, then there will be therapeutic failure. Okay, so decreased intensity or duration of action of drugs which are inactivated by metabolism. Okay, if one drug is metabolizing another, increasing the metabolism of another drug, so there is, for example, there is failure of oral contraceptive when these oral contraceptives are metabolized faster when taken together with rifampin. Okay, understood? Now what happens? These enzyme inducers, they can also metabolize some endogenous substances. Endogenous means inside the body. Okay, so substances from inside the body, for example, like vitamin D. Okay, so this can result in diseases like some endogenous substances are metabolized faster. For example, vitamin D metabolized by anti-epileptics, which will lead to osteomalacia. Osteomalacia is the disease caused by less calcium in the body, which is again due to less of vitamin D in the body. Okay, now, so what did we learn? In metabolism there is inactivation of the drug. Okay, but in some cases there is also activation. So when there is more of activation, there can be toxicity. Okay, so increased intensity or duration of action of drugs that are activated by metabolism. For example, acute paracetamol toxicity. So paracetamol is generally very safe drug, but this can become, very toxic. There can be acute paracetamol toxicity due to one of its metabolite. Okay, when the drug is converted to its metabolite, and that metabolite is toxic. Okay, so that can lead to toxicity. Now imagine you are on daily basis, you are taking some drugs to control, to control your BP, to control your sugar, and some anticoagulants. Okay, on daily basis you are taking, and suddenly you start taking the enzyme inducers. Then what happens? The daily dosage, whatever you are taking of these drugs, will be interfered. So interfere with dose adjustment for regularly used drugs when inducers are intermittently given. Okay, as in the case of oral anticoagulants, antihypertensives, and hypoglycemics. Okay, understood? So these are the clinical relevance. So there can be tolerance, there can be therapeutic failure, they can be like, it can result in diseases, there can be toxicity and interfere with dose adjustment. Okay, but this can also be useful in some cases. Okay, so what are the possible uses of enzyme induction? So when this increased metabolism will help us when the liver is not able to do it, right? So in the case of liver diseases, it will help, or when we naturally do not have these enzymes. So in congenital, means in the newborns, when there is not of enough, microsomal enzymes, then this can be helpful. So in congenital non-hemolytic jaundice, in some cases like Cushing's syndrome and chronic poisoning. Cushing's syndrome, as you can see in this image, this is Cushing's syndrome. Okay, so the main cause of this syndrome is steroid drugs. So if the person is taking more of steroid drugs, this can lead to this syndrome. So if you want these drugs to be metabolized faster, or in chronic poisoning, if you want the poison to be metabolized faster, these enzyme inducers can help in it. Okay, so in first two conditions, when we do not have enough of liver function, okay, then this is useful, or we want fast metabolism of drug. In these two conditions, it will be helpful. Okay, so this is about microsomal enzyme induction. I hope it is very, very clear and it is very easy now. Okay, so first you have to write what and how there is microsomal enzyme induction, then what is the clinical relevance, and then what are the uses of it. Okay, what are the possible uses of it. Now let's move on to the next question, that is the prodrug. Okay, so actually we already understood what is the prodrug. Okay, so what is prodrug? Prodrug is one inactive drug. Okay, so this inactive drug, so it is an inactive form of drug. Okay, now this is activated, so this prodrug is activated by metabolism in the body. Okay, so what are some examples? Levodopa getting converted to dopamine, enalapril converted to enalaprilat, acyclovir, this is nothing but antiviral drug. Okay, enalapril is antihypertensive, levodopa is nothing but it is the drug related to the CNS, okay, central nervous system. So this is converted to acyclovir triphosphate. Okay, so these are some examples. Now the question comes, why do we take some drugs in inactive form? Okay, because they offer some advantages, like the good things are happening more and the bad things are happening less. Okay, so there are desirable pharmacokinetic properties related to this prodrugs. So they are more stable and they give better bioavailability. Okay, if you want to understand about bioavailability, go to part 1 video of this pharmacokinetics. Okay, now so there is more of good things and there is less side effects and toxicity. So because of these advantages, we are in some cases we are using prodrug. Okay, so we are done with the question prodrug. Now let's move on to next question, that is first pass metabolism. Okay, so we are going to understand this in 5 simple points. Okay, 1, 2, 3, 4 and 5 points. Let's go with each one. So what does first pass metabolism mean? So again, it is a metabolism. So this refers to metabolism of drug. Okay, when it passes from the site of absorption into the systemic circulation. Okay, so what do you mean by this? So let's understand this with this example. Okay, so when we take any drug orally, it will reach the stomach and intestine, right? So the blood from the stomach and intestine with the drug, it will be reaching the liver first. Okay, that is called as portal venous system. Okay, so liver will analyze the drug, blood whatever is coming from the stomach and intestine, and according to the body needs, it will modify the blood constituents and then it will be given to the heart, and then the heart will supply to the entire body. Okay, so here the liver is acting as a screening machine kind of thing. Okay, so let's come to this statement. So when it passes from the site of absorption, so what is the site of absorption? Stomach and intestine. So from the site of absorption into the systemic circulation. So what is systemic circulation? This circulation. So it is the metabolism of the drug when it passes from the site of absorption into the systemic circulation. Okay, so whatever metabolism is happening in between that is nothing but first pass metabolism of pre-systemic metabolism, before reaching the systemic circulation metabolism, that is the pre-systemic metabolism. So where does it happen? So as we have already understood, for all orally administered drugs, it will be happening in the liver and the intestinal walls. For example, in the case of propranolol and salbutamol. Okay, so propranolol is antihypertensive, salbutamol is mainly anti-asthmatic drug. Okay, now this is very significant. Okay, so here the first pass metabolism is very significant. It can also happen in the skin and the lungs. When it will happen in the skin? When we are giving the drug transdermally. Okay, when we are applying it on the skin, then before reaching to the blood, the metabolism will happen in the skin. In the case of lungs, so in any case or by any route, if the drug is reaching the venous blood, so venous blood is the blood that is going to the lungs. Okay, so if the drug is reaching that blood, then it will be happening in the lungs. So at these two sites, it is happening at very limited extent. Okay, so you understood about the site. Now see what is the importance of it. So it is the important determinant of oral bioavailability. Okay, right. Now what are the attributes? How we have to be careful when the drug is having high first pass metabolism? First option is change other route. So prefer other routes of drug administration like sublingual, transdermal or parenteral routes. Okay, if you cannot do this, you have to give it by oral only, then increase the dose. So oral dose is considerably higher than parenteral routes. Okay, now in some cases this first pass metabolism is decreased. When it will be decreased? Obviously when the liver is not functioning well. In severe liver diseases, it is decreased. And when another drug is competing with first pass metabolism, then it will be decreased. Okay. Example is chlorpromazine and propranolol. Okay. So in these cases, first pass metabolism of the drug will be decreased. So we have read first pass metabolism in these 5 points. What does it mean? What are the sites? What is the importance, attributes, and when does this decreases? Okay, so this is all about pharmacokinetics. In next video we will see clinical pharmacokinetics. Okay. You can also join me for customized daily classes, and with these essential resources we will make your exam preparation smooth and successful.